Well, hello, everyone, and thank you for joining our COVID-19 webinar follow-up series. My name is Holly Foxworth. I'm a registered nurse with Axiom Medical, and I'm also joined by Chief Medical Officer Dr. Scott Cherry and Chief Marketing Officer Dara Wheeler. Welcome to the live stream.
Thank you, Holly.
All right.
Great to be here.
We have two CMOs, same letters, but different roles here. Well, before we get started, let me have you both introduce yourselves and kind of give us a little understanding and an idea about what it is that you do. Dr. Cherry, we'll start with you.
Yeah, hi, good afternoon, everyone. Thanks for joining. My name is Scott Cherry. I'm a board-certified public health and preventive medicine physician. I'm also boarded in occupational environmental medicine. I've been supporting military, industrial, and corporate operations from a medical perspective for the past 15 years. And so it's been a pleasure to talk to you guys about COVID during this pandemic.
Thank you. And Dara?
Hi, everybody. Nice to see you today. My name is Dara Wheeler, and I'm Axiom's Chief Marketing Officer. I have been with Axiom 14 years and really excited about where Axiom is going in the world of occupational health and medicine. So very happy to be here.
Love it. Well, as you guys may recall, last week, epidemiologist and principal for data strategy consultant, Sarah Marikas, and Dr. Cherry as well did a fantastic job on presenting on demystifying epidemiology and the role of public health. Unfortunately, Sarah's not able to join us today because she's helping with the involvement in the California wildfire response efforts. But it definitely was enlightening to get a firsthand account of all the coordinated resources that are associated with public health and disaster relief. The way that she spoke about having to evacuate the hospitals and the transports and getting medicines, it was nothing short of amazing for sure.
Yeah, Sarah is doing an amazing job out there. She's worked on many other situations in other fires up in Northern California, and not only dealing with the physical well-being of the local community, but also the mental health of the community as well as they're going through these traumatic events. So I know we all wish her well and safety and hope she gets through this unscathed as much as possible.
Absolutely. Well, we certainly appreciate all that Sarah and her team are doing, and for the state of California, we definitely want to keep them in our thoughts. But kind of shifting our focus to the webinar, we did have several follow-up questions that I was hoping that the two of you could provide a little bit of insight on. The first was from Nathan, who was asking about the role of public health in terms of distributing vaccines at both the state and the local levels when those are developed.
Yeah, and luckily Sarah did give us a few answers here, because although Scott and I have some expertise in this, I think that Sarah brings a very unique perspective in epidemiology and public health. Sarah did say that while vaccines traditionally are distributed through personal health and your personal physician and insurance, because this is a pandemic and we have a very critical role of the public health department in this pandemic, that the public health system will have a role in that vaccine distribution at the state and local levels. She said that traditionally in most states, public health will obtain the vaccine and then distribute to local public health officials and groups. So at this point, they're going to be deciding, and I think Holly has looked up into the CDC and how they've been thinking through this distribution plan and strategy, but they'll start to consider when, where, how those vaccines will be distributed following those state or national guidelines. Although Sarah did have the disclaimer that this is how it traditionally works. Now with COVID, there's a lot of moving parts and different components that are going to have to be taken into account. So Holly, I know that you looked into the CDC and some of their distribution guidelines.
Yeah, it did. It looked like that they had actually put together a task force. So I think that's what they're working on right now, is to just kind of get an overall plan on how that distribution process will work. And so hopefully we'll have some additional insight and ideas to how they'll be able to facilitate that in the coming days. All right, well then let's see, who's next? We had Carla was asking about what the significance of a 7-day moving average was when you're looking at positivity rates.
Dr. Cherry, if you want to start with this one, I've got a little bit of feedback from Sarah as well.
Sure. Yeah, what I can comment on this is that, statistics can really help us infer what's going on, and it's really helpful to understand the limitations and strengths to the statistics we're tracking. And, obviously the daily a daily average or the daily report of test case positives or testing are helpful, but there can be significant spikes day to day based on resourcing or if certain cities or communities are doing initiatives. And so a nice, more stable number would be to look at a 7-day moving average. That way you're taking into consideration every new day, but you're providing some stability by the trailing 6 days. And so that's kind of a helpful way to track some of these things that can be relatively unstable. So those are my thoughts on that.
Yeah, those are great points. And I think it also goes to the bigger picture of what you've talked a lot about, being careful about where you get information and the numbers you're seeing. So I do think that one of the benefits of the moving average is it does smooth out that data a little bit. And so you don't have, if people aren't testing on weekends as often or on holidays, and you've got these spikes and valleys, and just understanding how the data and how it's actionable. So I think that's what I see. If you follow a lot of your local public health departments and you see these statistics being presented by the public health groups and the public health departments, it often for everybody gets to be a bit confusing about what is the information that I need to understand what I need to be concerned about in my community. And often if you're looking at the brand new cases or those averages and understanding what it is that's being presented or the hospital beds available and these critical components of a pandemic and how in a local community we should be paying attention to those peaks and valleys. I think that's a critical aspect of this as well, and one that I do think people are becoming more and more challenged to understand.
Great points. And I think Sarah may have discussed this whenever we had the webinar before, but just reiterate again, why is it so significant to look at what your local stats show versus what it would show from a national level?
I can speak to that a little bit. What we're seeing with COVID, but it's probably very applicable to any outcome of interest, is that the U.S. is a very large nation, and that each state has a very different experience. And then every city or community actually will have a different experience as well. So, I think the national news will cover very broadly and then maybe focus in occasionally on a specific city. But even within your community, it's very important to know what's happening because there's so many different drivers with testing resource, with density of the community, which can be a huge driver for transmission, as well as the different social what was the word I was going to use? It's the social drivers of health. Yeah, the social drivers of health. So the prevalence of certain chronic medical conditions can change how an outcome manifest or how a city will manifest transmission of disease and severe disease. So really, you want to look in your local community as if at all possible.
Great.
Yeah, I think that's a great point too, and one that actually kind of goes back to some of what Dr. Matos and Dr. Cherry spoke about in a prior webinar as well. I think that the whole point of population health and public health, if you think about the way that it approaches groups and populations, it is so specific to a population, and that population can be as narrow as your local community, or like Dr. Cherry said, groups within the local community. And if you understand how to address and how to approach those different populations, it does change outcomes pretty significantly. So, Dr. Matos, I thought gave a great example of the firefighters that he's worked with, and understanding the health associated with a firefighter in a population versus the individual health for somebody that's a non-firefighter. And I do think that as we look at local communities and infection rates and different components, keeping in mind those different populations is also really important.
Good points. Very good points. All right. Well, the next one came from Roger. He had some great questions he'd heard about the importance of accelerating the testing process, getting faster results, et cetera. And so he's asking, can you explain how pool testing works and maybe circumstances or settings where it may or may not be appropriate?
Yeah, I can speak to that. Pool testing refers to having more than one sample being run during a testing cycle. I think what COVID has really demonstrated as a primary challenge is that testing resources is very limited, and that to be able to effectively surveillance and test a country with over 300 million people with a technology that's still being matured and then scaled. If we were to test a large, proportion of the U.S., it would take tremendous amount of testing resource. So pooled testing looks at being able to batch a bunch of samples from, a community, a workplace, and then run them as one actual test. So you drastically reduce the testing resource. And then what happens though is that if that pooled test is negative for any virus, then that whole population being tested is considered negative. If there is a positive from that pooled test, then everyone individually would need to be tested. So getting to that second question about would it be appropriate for a school or college campus, it depends on the prevalence of the disease or the kind of the baseline level of disease of COVID. So I think it's to be determined at what prevalence level, would 50% of the community or of the population being tested have it, 10%, 1%, but you really want to have a very low prevalence, because the goal is that you want to test a large number of people in this batch testing, but as soon as you get a positive, then you have to run everyone individually. And if there's a high prevalence of disease in that population, then you're going to have a high probability of getting positives and then having to test everyone individually. So probably the bar of 1% or 5% is probably a good estimate of prevalence to be able to do pooled testing.
Those are great points, and I do think the question about schools or colleges, again, I think it would depend on the community that the school or college existed in. We've already seen in the news yesterday a couple of the universities that opened up back to in-person classroom training and education have already shut back down because of outbreaks and minor outbreaks on those campuses. So doing pooled testing in the midst of an outbreak is definitely not the right strategy, or in a location that we know there's a high prevalence of the infection. So I do think it's a really interesting way to develop testing as we kind of come through this, but it would be definitely need to be strategically utilized in very specific instances and communities.
And just to tie back to one of the first questions, you could use that 7-day rolling average as a good proxy for prevalence in the community. Whereas if you used today's or yesterday's data, you would have a less certainty or less precision on the confidence of that estimate, so something to just kind of tie back the previous question.
Good point.
That's a good point.
Okay, our final question came from Belinda, who's asking if we could kind of talk through how case surveillance information is reported. Does that flow from the local health department, like to the state, and then on to the CDC, or how does that process work?
I can start with that, Dr. Cherry. So I do have Sarah's response too, and that is something she's got a lot of expertise in. She said usually, yes, cases are reported locally, and then it moves up the ladder. So you've got the local reporting, state, then CDC. And her experience in California has been that in California, many or most states do get electronic lab reporting. Then the local and state departments are notified at the same time. And then locally, they investigate, they respond. And if for some reason electronic lab reporting isn't used, then the case gets reported at the local level. They input the data into their system, and then the state gets notified from there.
Okay. Dr. Cherry, did you have anything to add to that?
Maybe the only thing I would add to it would be, there's several different types of tests out there for COVID. And so obviously, as you get to a more aggregate level, so if you go from one lab to the local health department to the state, then to the national CDC, all those numbers are potentially conflated or mixed. And so I think your local health department will give you the best information what's happening locally. So are they using, the nucleic acid test? Are they using an antigen test? Are they mixing in antibody testing? I know for a while there with Texas numbers, they were putting both antibody and nucleic acid tests together. So for that period of time before they annotated that, it actually looked like there was larger number of infections, when we know the antibody test is actually the immune response to the infection, not the actual infection. And so it could be a proxy depending on which antibody, but in general, I would suspect most antibody tests were showing prior infection, not current infection. So you could be double counting, things like that. So again, your local health department would probably have the best, most granular information to act upon.
Yeah, and back to kind of my point about when you follow local public health departments too, often that becomes I like to read comments and see how the community is responding to different posts or different statistics, and often I see a lot of response about double counting and how can you trust some of these numbers and these statistics. And it is an interesting component, because I know one of the things that Dr. Cherry and I have faced a lot recently is persistent positives. So if you have an individual who has been positive prior and continues to test for their job or for other reasons, does the public health department all the way up to the CDC, do they report every single positive as a new positive? Or is it the first positive, and if somebody's persistently positive, do they change the way they report that? And Dr. Cherry, I don't know if you know the answer to that. I just thought it was a really good question that I've heard kind of come up once in a while.
Yeah, I don't know specifically. I know that now, based on CDC guidance, to not retest someone who's tested positive under the nucleic acid test within 90 days of their first positive, that's a very strong indication that that phenomenon is actually happening, that people are actually testing many times positive even when they've recovered. And just for those who haven't heard of this persistent positive, so when you do the PCR test for nucleic acid, when someone has recovered their infection, their symptoms, if they were to get a test within 90 days, there's a lot of data that shows that more likely than not, or maybe even 99% chance that the test, if it's positive, it's picking up remnants of pieces of the genetic material from non-viable virus, because they haven't demonstrated any secondary infections from those people. And that just speaks to how sensitive of a test the PCR is. And, I would just say that, a large country like ours that has, such a large organization like the CDC being the final repository of this information, they are not going to be able to track the nuance at the local level. And so it may be helpful to know that when, if you're just very curious in your community, but it is a challenge.
Yeah, that's a great point. And I do know that one of the benefits of the PCR test that everybody's loved is how sensitive it is. However, the downside has definitely been this issue around persistent positives. And I do think that as we look to other testing strategies, layering, like you've said, different types of testing into that process will be interesting. It'll be very interesting when we kind of come through this, hopefully at some point in the near future, and we start looking back at the data and what it means for future pandemics.
Yeah, the persistent positive is something I've been thinking about more lately, because again, it's becoming more mainstream versus discussion amongst test providers and healthcare providers. But what's been very challenging is that probably up to a third of infections are considered asymptomatic based on the data we have. But now that this persistent positive becomes more well-founded, it makes me rethink that maybe a lot of these asymptomatic infections are actually persistent positives from a previous illness, a while back, maybe a very mild illness. And so I think like specifically in some of the jails, there was a very high rate of infection, maybe over 90%, but actually all of them were asymptomatic. And so I actually think on the balance of probabilities is that those were persistent positives, not actually infections. But just something to discuss for the group to consider, you know.
Yeah, that's really fascinating. And, I've thought about that a lot too recently as we see more of this data coming in and hearing more of the anecdotal stories of people that are asymptomatic positive. I do agree. And I think that, we're all hearing stories of that with family and friends as well, wondering if the flu that they had in December or January was actually COVID, and then later on down the line, testing antibodies and testing potentially PCR and becoming positive, it really was the prior infection that is lingering, and there's some lingering virus particles there. So it is something that creates just another complication to this wonderful world of COVID.
Yet another uncertainty. Yes, definitely. Any closing remarks before we wrap up?
I can go first. COVID continues to be very challenging. Early on, we didn't have testing, so we were doing syndromic surveillance. We thought testing would be very helpful. It is very helpful in a lot of ways, but it also adds a lot of noise to our clinical and programmatic decision making. And so I think what we've all found at Axiom is having a layered approach where you're addressing the risk in many different ways, from symptomatic screening, symptomatic testing, and then also maybe even active surveillance or prevalence testing of just random testing in the population, but also having all of the preventive measures that we've learned through flu, and then having effective return to work policies that allow for insurance that people aren't being returned too quickly following the CDC guidance. And so I'll leave it at that.
Thank you, Dr. Cherry. I want to say a few things. So first, I want to thank Sarah for having been on last week. It's been it was good information to hear about what an epidemiologist does in the public health department. And I do think Sarah said this either before the webinar or during. It is interesting for those of us that have been working in these niche industries and in these areas of public health and population health. For the first time, the general public is very interested for obvious reasons, and it is bringing some unique opportunities for those of us in this world to bring some expertise and hopefully some reassurance as we learn more and more about this infection and how we can support the overall public health and population health of our communities. So I really appreciate the opportunity to jump in for Sarah and have another great conversation with Holly and Dr. Cherry today.
Perfect. Well, Dara and Dr. Cherry, thank you both for joining us today and for answering these additional questions. Just before, a few quick mentions before we go. Next Thursday at 1:00 p.m. Central, we're going to be hosting another webinar on preparing and responding to increases in pandemic drug activity or positivity. So we're going to have both Dr. Cherry and Dr. Shaw, who's a neurologist and addiction medicine specialist. They're going to walk us through some of the trending numbers that are there and provide some insight on the mental health perspective as well for substance abuse in the workplace. So if you haven't already, please make sure and sign up for that and send us your town hall questions in advance to coronavirus@axiomllc.com. We also have a new white paper which addresses the Hollywood entertainment industry and getting back to business with a multi-layered comprehensive medical approach. So that walks you through the role of the health safety supervisor, mandatory zone testing for cast and crew, and then also virus transmission and positivity rates. So you can access a free copy of that on our website. And as always, should you have any questions regarding Axiom's Check Into Work or Check Into School apps, please reach out. We're happy to walk you through. So thank you again. We look forward to talking to you Thursday at the webinar, and stay safe.
Thank you, Holly.
Thank you.